All right, I think that means it's time to get going. So, on behalf of the Washington Academy of Family Physicians, let me welcome you all to our third module or third installment of the Business of Medicine series. I know here in Bellingham, it's a beautiful sunny May evening, so it's not lost on us that you've committed to spending some time with us. So hopefully this time is valuable for you. So our topic for tonight is around payment and the evolution of payment, evolving payer-provider agreements, family physician contracts, and value-based care. And as a reminder, this meeting is being recorded, and so that is simply so that we can post it online for folks to watch at a later date. So let's dive into the agenda for the evening. I will start with some brief introductory comments. We'll talk a little bit about the purpose of payer-provider contracts, talk about basic payment models, specifically fee-for-service, capitation, and then I'll spend a slide or two talking about DPC, which is direct primary care. I know in the follow-up feedback surveys we've distributed after the first and second module, there's been some interest in hearing more about direct primary care, so I'll speak to that briefly. And then we'll talk about contracting things beyond those basic payment models. So we'll talk about the variety of different incentives that are increasingly appearing in payer-provider contracts. We'll talk a little bit about profit sharing and shifting risk as these contracts evolve over time. And then we'll define value-based care, or VBC. We'll talk a little bit about making care primary, which many of you are probably familiar with. It's a new CMS initiative. And we'll use that to illustrate what a sort of typical layered contract would look like these days with a value-based care approach. And then we'll talk about how value-based care is shifting more money towards primary care, which is great news for all of us in family medicine. And then we'll end with question and answers. And I do want to call out that I will make some comments throughout the presentation highlighted in yellow as to how some of these contracting components directly impact employed physician contracts. So again, I know a large percentage of family physicians in Washington State are employed. So this is going to be something you all will be familiar with, but hopefully tonight you'll understand in a bit more detail why those contracts are written with certain requirements and incentives that they often have built into them. And then I just want to remind you that videos from modules 1 and 2 are posted on the WAFP website. That's the URL there, but you should probably pretty easily be able to find it on the WAFP website. In the interest of time tonight, I'm not going to review the first two modules. The content of the presentation tonight is a little bit different than what was presented in those two, so feel free to review those on your own time. So. Just as a quick introductory comments, a reminder of our goal with this Business of Medicine series. So in 2 words, the goal of this series is physician empowerment. And again, put a little bit more eloquently, with additional knowledge and understanding, our hope is that family physicians will feel empowered to regain a sense of autonomy and control, which they can use to improve patient care and increase professional satisfaction. I was just having a conversation today with one of my colleagues here at Family Care Network talking about how medicine is really a career in medicine is a marathon, not a sprint, right? And so how we think about our work, how we do our work, the emotional impacts, the mental health impacts, the physical impacts of that work, it needs to be sustainable over time. So when we think about what we're trying to do here, we're trying to provide tools to family physicians around the state so that they can sort of pace that marathon, that they can manage their professional satisfaction, and that they have the leverage to improve patient care, which is obviously why we go into this and to begin with. Just as a reminder, this whole series is put on by the Professional Affairs Committee, but there are 4 people on this call that are very helpful in organizing all this. So Jordan, Lynn, and Alyssa are all listening in and facilitating. So thank you to them. And as a reminder, we will save questions and answers to the end of the presentation tonight. So if you have questions, feel free to drop them in the group chat, or if you want to ask that question kind of anonymously, you're welcome to send that question directly to Jordan, and then he will facilitate the Q&A at the end. So, and again, we'll spend as much time as we need to at the end. And just as a reminder, there is no question that you can ask that would offend any of us or is off limits in any way. So again, don't hesitate to get those questions out there. So, as we always do, announcing conflicts of interest. I don't have any conflicts of interest with anything that's presented through this series. But again, as a reminder, I do have some opinions, and I would just reiterate that the way that we're approaching this and teaching this is just one approach. This subject matter could be taught different ways by different people, and it wouldn't necessarily be more right or less right. It's just different perspective and different opinion. So again, the goal tonight, as it is with each module in this series, is really about framework and broader understanding, not really about nuts and bolts specifics, but to try to kind of reframe how we think about the business aspect of the work that we do. So returning to our sort of simplified model of healthcare, and we showed this on the very first, we talked about sort of the 3 Ps involved in healthcare. So in the top left, you've got provider organizations. So those are physicians groups, hospitals, et cetera. Top right is payer organizations. So these are insurance companies, often private insurance, but obviously there's a government component to that as well through CMS and then state Medicaid agencies. And then finally, we have patients as the third P. And so in each of these series, we're gonna, or in each module in this series, focus on a different component. And the focus tonight is on payer-provider contracts. So you can see highlighted in red sort of how providers get paid by payers and then what payers get out of these contracts as well. So that's really the sole focus of our time tonight. And different than our previous 2 lectures, I'm not going to start the evening with an economics lesson, which many of you might be thinking, whew, tired of hearing about the history of economics. That's not what we'll be talking about this evening. So let's go ahead and dive in here. So I'm going to start at a very high level and just give a perspective on the whole purpose of payer-provider contracts. And so I would think of this as what is the payer perspective on these contracts, and then what is the provider perspective? And by provider, I mean healthcare organization, healthcare providing entity. So again, could be hospitals, could be multi-specialty group, medical group, single specialty, and et cetera. So from a payer perspective, contracts are critical first because they create a credible network. And I think you've all heard that term network. But it's worth explaining that in order for an insurance company, a payer, to sell an insurance product, and again, these are private payers, in any given county in Washington state, they need to have approval at the state level to sell that insurance in that county. And part of the approval process is to ensure that that payer has a credible network. So typically what that means is they need to have access to primary care, they need to have access to specialty care, often need to have access to hospital care as well. And so payers really can't sell any products without a credible network. And that network is demonstrated by the contracts that they have built with local healthcare providers. So again, from a payer perspective, these payer provider contracts are absolutely essential in order to operate their business. And then the other kind of big piece with this is, from a payer perspective, ensuring that their members, which is what they refer to patients as, their members, have access to healthcare, both providers and facilities, so hospitals and such, while managing the cost of that care through contracted rates and what are often referred to as narrow networks. So remember, the economic model for payers is they take money in through premiums typically, and then they pay money out in healthcare costs. They want to manage those costs effectively as possible, so they negotiate those payment rates in advance, and then they often work under what are called narrow networks, which basically means that patients can't go see every specialist or go to every hospital or see every single primary care provider in a community. They've shrunk that down to a smaller group. Some might sort of pessimistically say that's to reduce access and limit costs that way. Others would say, payers would say that narrow networks allow for more cost-effective management of the care that's being provided. But again, it's important to appreciate that payers have to have these contracts signed in order to demonstrate a credible network so that they can do their work. And then on the provider side, a couple bullet points here. So provider perspective on payer-provider contracts, it's to provide care and gain access to a broader number of patients by being in-network. Remember, us as healthcare providers don't have to sign these contracts to provide care. In fact, direct primary care is an example of not signing any contracts with any payers or any insurance companies. But typically, the reasons why providers will sign these contracts is so that they can provide care to a larger sort of subset of the local population. And again, once they have a signed contract, they're typically described as being in network. And then there's marketing that comes with that, right? So when my organization, Family Care Network, signs a contract with Premera, as an example, Premera can now list on their website and through their brokers, communicate out to the public that if you sign a contract with Premera for insurance, you have access to Family Care Network and Family Care Network physicians. And so again, there's benefit in that way. And then there's also, from a provider perspective, the goal of establishing in advance payment rates for services that they provide that are reasonable. And so basically you're negotiating compensation in advance. And we'll talk about the details of how those contracts are negotiated and what that compensation looks like and what it's tied to and such. But from a provider perspective, we're basically saying we want to know that if we provide care to, say, Premera patients, that we will be paid at a pre-agreed upon rate that we perceive as being reasonable for the services we provide. Now, we've talked in past sessions about how that gets distorted oftentimes with monopolies and such. We're not going to get into the weeds of that today. Again, we're just going to keep it at kind of a higher level and outlining what these contracts typically look like. So, and it's also important to call out, this is true with every contract that's ever created, not just in healthcare, that contracts create incentives. And incentives can sometimes drive behaviors that are not in the patient's best interest. And I'll explain that a little bit more. It is unfortunately true in healthcare that sometimes these incentives, which on the surface would seem like they might align behaviors, can be distorted and taken to an extreme if folks are pursuing financial gain above high quality patient care. And so again, contracts create incentives. And so as we talk about how contracts have evolved, it'll be pretty obvious the incentives that are trying to be created. And again, how those incentives potentially can be distorted over time. So again, I think a big take-home message here is contracts serve different purposes for the two parties, but again, incentives are always created. So let's talk about basic payment model. So every healthcare sort of payer provider contract I've seen usually has an underpinning of kind of a baseline payment model and then has other components stacked on top of that. So the most basic payment model is called fee for service. Forgive me if this is a bit of a repeat for some of you, but fee for service is exactly what it sounds like. You are paid a fee for every service that you provide, or for every service that is provided. This is pretty similar to how much of the non-healthcare world, service world works and looks like, right? So if I have to hire a plumber, I just pay the plumber for that service that they provide when they come out to my house. If I have to hire an electrician, if I have to hire an auto mechanic, whatever service they're providing, I simply pay them for that service. So that's a pretty simple, pretty obvious model. In healthcare, the idea of a services are defined by CPT codes. I think we're all familiar with that. So CPT codes are E&M codes, they're procedure codes. There's a list of more than 10,000 CPT codes. And somewhere in my office here, I have the CPT code book, and it's a gory book. But there are a lot of CPT codes. And again, those are defined and then redefined every few years. That list of CPT codes, but that really defines what distinct services exist in healthcare. We as family physicians are probably most familiar with those classic E&M codes, but again, those are just CPT codes. And so each CPT code, we probably all know this, has an RVU value. RVU stands for relative value unit. And so it's a numerical value attached to that CPT code. And we'll talk about the different components of RVU. But again, CPT code's RVU value is significant. And it's the relative weighting of, the relative RVU weighting of each CPT code that actually drives monetary payment for the services that are provided. And so we'll walk through on the next slide exactly what that looks like, but understanding that the CPT codes you choose and the associated RVU value of those CPT codes actually drives the monetary reimbursement that you receive in a fee-for-service model. And I would say that fee-for-service payment model makes sense for episodic care. And again, if we pull this outside of healthcare and think about like a plumber, I don't want to pay a plumber a subscription fee every month. I just want to pay a plumber when they come out to my house and fix the clogged drain or what have you. So a lot of the work that happens in healthcare is episodic. So emergency room care is probably the best example, right? I don't set foot in the emergency room for 10 years, and then all of a sudden I need them, and I need them urgently, and I need them for some intense care episode. I should just pay for that sort of episodic care as it comes up. It will be paid for. So again, fee for service really reflects episodic care. Now, traditional Medicare, when it was originated in 1965, fee-for-service payment model, and it sort of has been all throughout, although we'll talk about making care primary and some other creative payment models that CMS is experimenting with. But that fee-for-service payment model, I would suggest that 50 years ago, that model probably made sense because all of healthcare, including primary care, was much more reactive than proactive, right? We weren't talking as much about keeping people from having heart attacks and strokes. We were just responding to those acute episodes when they occurred. But as you all know, that's not what a lot of healthcare looks like, especially primary care and family medicine. So let's in kind of visual form think about how this fee-for-service model works. So first, let's talk about these RVUs, or relative value units. So on the right side, you see a box that says total RVU value, and that's for a given CPT code. And then it's worth remembering that that total RVU value is the sum of RVUs of three separate components. There's a physician work component, which is called a work RVU, or sometimes abbreviated WRVU. There's a practice expense component, and then a malpractice component. The physician work component is supposed to reflect the amount of time and energy and work that a physician puts into that individual CPT code. So that's often you'll hear organizations measure their physicians against work RVU specifically, because again, it's really supposed to recognize the physician work component. But in fee-for-service models, it's that total RVU component on the right side that is really the basis of compensation. And then the way the math works out to get from a total RVU to actual monetary compensation, you take that total RVU value for a given CPT code, and not to complicate things a little bit further, but the relative RVU values of different CPT codes vary a bit year to year. So there is something called an RB-RVS. I think it's actually RV-RVS. I think I typed that wrong. So it basically outlines how much every single CPT code is worth in any given calendar year. So when you're negotiating a contract, first thing you have to designate is what is the RV-RVS year that you are using. And then what is negotiated typically is that center circle, that conversion factor. So essentially, how many dollars are we going to be paid per RVU, per total RVU? And then for any service that's provided, you simply take the total RVUs of that service, you multiply it by the conversion factor, and you get the actual monetary payment to the organization or to the individual. So again, these key components: what are the CPT codes that are captured? What is the relative RVU weighting of those CPT codes in any given year? And then what is the negotiated conversion factor that actually drives the actual monetary payment? Now, interestingly, with CMS, they're always on the current year RV-RVS schedule. That's probably not surprising. And with CMS traditional Medicare, there is no negotiation of a conversion factor. In fact, you see every year in the media what the conversion factor is doing. I think for 2024, it went down 3.36%, and that's always publicized because it has huge impact on actual monetary payments. When these contracts are negotiated with private payers, you actually select the designated year of the RV-RVS, and then you negotiate around the specific conversion factor. So again, this is the fee-for-service model. And as we think about employed physician contracts, and you think about many contracts requiring that certain RVU or work RVU targets be met, you can see exactly why. The true monetary payment, the revenue generated for the organization through a fee-for-service model, it absolutely depends on total RVUs. So physician contracts often say you will generate X number of RVUs, or these are your RVU targets, or what have you. This is what's behind it. It is the direct driver of monetary payment. So that's the fee-for-service model. Let's dive into the next kind of basic model, which is a cap or capitation model. And so whereas fee-for-service, you're paid for every individual service unit you provide, in capitation models, providers are paid a fixed, what's typically called a per member per month, or PMPM rate, for each attributed member, essentially each patient you take care of, regardless of how much care is provided to that patient in a given month. So this is essentially a subscription model. I think of this like Netflix, right? So you pay a monthly fee for Netflix, and it doesn't matter whether you watch 0 hours of Netflix or hundreds of hours of Netflix in the month. That monthly fee is the exact same. That is, in essence, what a cap model is. So you have an agreed upon per member per month rate for each patient that you take care of. They're called attributed members, regardless of whether you see them 0 times or 15 times in that calendar month. Now, that whole idea of an attributed member doesn't seem like a significant thing, as you think, oh, it's just the patients I take care of. But in these models, or in these payment agreements, there are often complicated attribution models as to how patients are assigned. But these models really are trying to define who is this patient attached to. So again, who gets the PM rate for this patient? And sometimes it's a little confusing and screwy. So like if a patient actually sees 2 primary care providers, trying to figure out which one might get that cap rate can get a little confusing. But if you ever get deep into a capitation model, understanding the attribution model is significant. So what does the sort of visual image of a capitation payment look like? It's a little simpler than the fee for service. So it's that per member per month rate. That's a negotiated amount. and you just multiply that by the number of attributed members, and that's the monthly capitation revenue. And so again, that's simply how the math flows. A couple other comments about capitation. CAP models typically define very explicitly which services are included in the CAP, or whether something's in CAP is the expression that's often used. And so it's pretty common for primary care providers that not everything we do is included in that CAP payment. And so, if you do OB work, if you do extensive procedural work, some of those things are not going to be included in CAP. And so any of those services that are outside of CAP, they're typically called carve-outs. I should have written that, but I didn't. They're called carve-outs, and they're often paid in a fee-for-service approach. So again, you see a patient for an E&M visit, that's a sort of a part of the CAP payment, but you also do a complex skin procedure. Well, you may, for that patient, still get that CAP amount per month, but then for that complex skin procedure, you're actually paid in a fee-for-service approach for that. So you would have additional payment potentially for that. CAP payment models make sense when care is continuous rather than episodic. Again, so we talked about fee for service. You don't go to the ER for 10 years and then you show up. I personally think that capitated payment models make a lot of sense in primary care these days because care is continuous, whether we see the patient or not. We're thinking about the patient, we're managing patients, we're outreaching to patients, we're recalling patients. All this work that we do, it doesn't really matter whether the patient's right in front of us. We are providing care to that patient in a continuous fashion. The other really nice thing about capitated payments is it creates a guaranteed income stream or guaranteed revenue stream. And so interestingly, like for my organization, Family Care Network, in the early months of the COVID-19 pandemic in 2020, while we saw our fee-for-service revenue diminish because patients weren't coming into the clinic any longer, weren't seeking care, the CAP payment just marches along very consistently. So it creates a nice kind of predictable income stream for primary care. And then I would also call out that CAP models provide flexibility to primary care providers in that you are not constrained by CPT codes in how you provide care. So as an example, this has changed a little bit recently, but if you go back 10 years, phone calls didn't have CPT codes attached to them. Web messaging didn't have CPT codes attached to them. I'm not sure 10 years ago if telemedicine even had CPT codes attached to it. That wasn't much of a thing 10 years ago. And so when you thought about how you provided care to a fee-for-service patient, you wanted to try to ensure that the care you provided would be reimbursed. And so spending 15 minutes on the phone with the patient, you get paid $0 in a fee-for-service model. You would often ask that patient to come back into the office and sit down for a visit so that you could bill an E&M code for an in-person visit. You could argue that that's an inefficient use in certain circumstances of the patient's time and of the PCP's time. In a CAP model, it doesn't really matter how you provide that care because you're paid a consistent way. So if you just want to email a patient with their lab results and that's good for the patient, great. That might be an easy way to do it. If a phone call is easier, fine. If you want to get them into the office, fine. Your reimbursement doesn't really depend on the exact sort of mechanism or method by which you provide care. Of course, you obviously want to continue to provide high quality care, but you can tailor that a bit better to each individual patient's preferences and needs. And so again, if we think about what does this look like for family physician contracts, CAP payments are really tied to CAP payments are tied to the number of patients you mandate. And so employed family physicians contracts often mandate certain panel sizes or encourage certain panel sizes, right? The more patients that are attributed to you, the more capitation revenue that comes in. And so I know for some employed family physicians, their contracts set RVU targets as well as panel sizes and such. Again, I don't know if that says that the organization that's employing those family docs has fee-for-service and CAP contracts, but again, you can sort of link how certain contracts would create certain incentives in those physician contracts. So let's switch gears a little bit and talk just briefly about direct primary care. And I'm going to apologize, this is a little bit of a wordy slide, but I'll buzz through this relatively quickly. So direct primary care is typically a CAP model, but payment, often referred to as a monthly fee, comes directly from the patient rather from an insurance company, right? So DPC is basically direct agreement between patients and healthcare providers, and it pushes insurance out of the picture. These monthly fees vary greatly. They're often in the range of $75 to $125+ per month. That doesn't include an initial sign-up fee. which some DPC offices have and some don't. And so again, there's probably as many different forms of DPC and contract models around DPC as there are DPC providers. But again, I'm just trying to kind of paint in broad strokes what direct primary care is. But I think of direct primary care as essentially a capitation payment model. Direct primary care practices clearly define the services covered by the monthly fee. It's similar to a capitated agreement with a payer where you define what services are in cap. These services are almost always limited to the care provided directly through the DPC clinic. And so again, it's sort of like everything we do in our office is included and everything that happens outside of our office is not included in that monthly fee. I will say that I've seen many DPC practices negotiate discounted rates for peripheral services. So they'll go to the local imaging and say, can our patients get x-rays at half price or something like that? Or can we get labs at a discounted rate? So again, the DPC practice will often negotiate that and then pass that along to their patients or their members. An important point is direct primary care is not considered insurance because the practice is not assuming broader risk beyond the services they provide. So DPC is really a subscription model, but it's not insurance. And it's really, again, there's no guarantee. If a DPC patient goes into the hospital, the DPC practice says that's outside of the scope of what we provide. So again, the DPC practice is not taking on broader financial risk, and thus it's not considered insurance. I will say that the revenue per patient is often higher in direct primary care practices. I can tell you in Family Care Network, we, with our payers, do not negotiate monthly PMPM rates of $75 to $125 a month. But again, that's not uncommon in direct primary care. And so as a result of this, these DPC practices do often have smaller panels and often longer appointment times as well. And then as a general statement, and again, I don't want to sort of paint every DPC practice identical, but because of those financial constraints, that monthly fee, that initial sign-up fee, direct primary care practices tend to be higher socioeconomic status patients, those that really can afford those fees. So I know that DPC movement is certainly growing. More and more people are interested in it. I think it reflects how fed up people are in terms of working with insurance companies. And I would make one other kind of interesting comment is that there are organizations experimenting with incorporating direct primary care into larger practices with varied payment models. So I think sometimes people think, if I want to try DPC, I have to go start my own thing or join a small DPC practice. That's not true. Increasingly larger organizations, my organization, Family Care Network, as an example, does have some local DPC contracts with local employers. We're sort of experimenting with that model. So it will be very interesting over the years and decades ahead to see how this all shakes out. Does DPC grow increasingly? Again, how does it all play out over time? So again, those are the basic payment models. So fee for service and capitation, and then direct primary care, I would just think of as kind of an offshoot of capitation that pulls insurance out of the picture completely. Let's talk a little bit beyond the basics. So increasingly over the years, more and more incentives have been built. These are often referred to incentives, have been negotiated into contracts between payers and providers. And so while fee-for-service incentivizes providing more care, that is generating more work RVUs, and capitation incentivizes taking on more patients, right, because you're paid a per member per month rate, neither of those models really directly incentivize providing high-quality, cost-effective care. Right, so those basic models, fee for service and cap, it's like, well, however many work RVUs you do, we'll pay you, or how many patients you take care of, we'll pay you. But it's really not recognizing what does high quality care look like, what does cost effective care look like. And so the different incentive kind of models that have emerged really address those thoughts of high quality, cost effective care. So let's talk about high quality first. And I want to make an initial comment that often upsets family docs. In that we use the term quality, defining quality. I would just call out that healthcare as an industry has gravitated towards things that are objectively measurable when we use the term quality. And so things like, and we'll talk about these, but preventive care type things, chronic disease management type things, these are objective, often numerical things that we can measure, and we use the term quality. I think it's important to acknowledge that those things do not fully define what a high quality family physician is. And in my organization, we try to use the term measurable quality because that's not the same as holistic quality. It's just, these are the things we can measure. And so that's why we're looking at them. That's why we're studying them. Many organizations do attempt to measure these non-objective quality components through patient surveys, but we all know that response rates are low to patient surveys, and they're often skewed towards patients with negative experiences. And I put in parentheses, often patients who had unreasonable expectations. So you all know the classic story. A patient comes in and said, I've had a runny nose for 3 hours and I think I need antibiotics. And you say, I don't think antibiotics are indicated for your 3-hour runny nose. And it's probably a virus. Let's give it some time. Let me know if it doesn't get better. And the patient walks out and writes a scathing review online because you're not a good listener and you didn't do what they wanted and such. So again, many organizations use patient surveys or patient satisfaction surveys or patient experience surveys. Some organizations choose not to. My organization doesn't because we think they're bullcrap, personally. But again, that's some do, and some organizations are required to for what it's worth. So hospitals often have to do some surveys. So, but again, these are attempts to measure those soft skills: communication, compassion and empathy, bedside manner. These things that we know are really important in defining high quality primary care, but they don't fit nicely into numerical models. So. And then what does cost effective mean? This has to do with utilization. And utilization is a term that reflects how much healthcare our patients are utilizing, how much care is being provided, and really assessing whether that utilization is appropriate. So I'll talk through that a bit more on the next slide. So again, broadly speaking, these incentives are often built around quality care or measurable quality, and then cost effectiveness. So let's look at these kind of one at a time. So preventive care measures, these are common incentive measures. So cancer screening rates, breast cancer, cervical cancer, colon cancer, vaccinations, very common thing to measure. Well care, well child care, well adult exams, annual wellness visits for Medicare patients. Other screening tools, PHQ-9 is increasingly showing up in some of our contracts. Are we doing those on every patient? Are we doing those on every patient with a diagnosis of depression? Yada, yada, yada. So that's the kind of broadly a preventive care bucket of incentives. There's another bucket around chronic disease management. So the most common diseases that I see measured are diabetes, hypertension, hyperlipidemia, and depression. And the measurements are things like having a hemoglobin A1C in good control, getting a diabetic eye exam, what the most recent blood pressure reading was, so whether patients are on statins appropriately, medication compliance with depression, and PHQ-9 screening and measurement on an ongoing basis. These types of things related to common chronic disease management. There are those patient surveys. Again, this is the less objective, but HCAHPS, Press Ganey, there's a very long list of different patient surveys. I'm no expert on those, but I know they are done, and I know they are the cause of much consternation amongst family physicians. Some of our local hospitals do those, and I know it frustrates our docs to no end. So, and then utilization. So utilization, some common measures for utilization are ER visits. And they're often measured in things like ER visits per 1,000. So per 1,000 patients that you take care of, how many go into the ER in any given interval of time. Hospital admissions per 1,000 is a common one. Generic prescribing rates. So when there is a generic alternative, what percentage of the time does your practice choose the generic? How often are advanced imaging studies done? What about specialty referrals and patterns around those? It's basically looking at all the things in medicine that cost money and where there are opportunities to save, and then measuring how you're performing against those individual things. So these first three buckets, preventive care, chronic disease management, patient surveys, really focus on that idea of quality. And then that utilization bucket really focus on this notion of cost effectiveness. And so again, as we think about family physician contracts, they do often establish financial incentives for meeting these quality and utilization targets. I imagine for those on the call, some of these things are very familiar because these are very commonly measured things, and they are often written into these contracts. And it's worth calling out that part of the reason why payers are comfortable putting these into contracts is because they can then attest to the fact that we provide high quality care, we provide cost effective care, and they have some data to support that when they're selling their products. So again, these are the most common incentives that I see layered on top of those basic fee for service or capitation payments. And then I want to talk a little bit about risk and profit sharing as another kind of layer to how contracts are often created. So this is obvious to all of you, but insurance companies bear financial risk. That's what kind of all of insurance is, right? So I pay a small fee every year for homeowners insurance so that if my house burns to the ground, I don't have to pay for it out of pocket to get it rebuilt. The insurance company will do that. So that's what insurance companies do. This has historically been true with health insurers as well. Obviously, that's what health insurance companies do or payers do. Healthcare providers historically have not really taken on risk, but this is starting to change through these contractual agreements. So Private insurers increasingly are negotiating what are often called profit sharing. Some people don't like that term, so they call them gain sharing arrangements or gain sharing agreements with healthcare providers. And basically, in these arrangements, if the health insurance company runs a profit on a specific subset of patients that healthcare provider is managing, then that profit is shared with the healthcare provider. So let's use a kind of tangible example. So let's say Family Care Network, my organization, takes care of 10,000 Regence patients in a calendar year. And Regence at the end of the year says, on those 10,000 patients, we made $100,000. And they've said, well, Family Care Network will get 30% of whatever profit we have. Family Care Network then gets $30,000. So that's what a profit sharing arrangement might look like. Private insurers often ask providers to also take what's referred to as downside risk, which essentially means that if we talked about sharing profits, but if the insurance company runs a loss, so if there's a loss on those 10,000 Regence patients, who pays for that loss? And historically, it was always the insurance company that bore that risk. But in some of these new agreements, the provider organization potentially bears some of that risk as well. So let's say on those 10,000 Regence patients, instead of a $100,000 profit, there's a $100,000 loss, and maybe the contract says Family Care Network is responsible for 30% of that loss. That's kind of a weird place where provider organizations are potentially paying funds back to insurance companies, but again, those agreements do exist. And so in taking downside risk, these arrangements really should not be called profit sharing, but should be called profit and loss or profit loss sharing agreements, because again, there's the potential for a negative financial outcome for providers. I do think it is hard for primary care, for pure primary care organizations to take on downside risk because there is a limit to the total cost that family physicians can control. We often say to our insurance partners, hold us accountable for everything that we can manage. And so when it comes to a patient, ends up with a massive subset of specialists who all refer to each other and costs just, get out of hand, there's a limit to how much we as a primary care organization can manage independently. So again, taking downside risk is a pretty scary thing if you're a small organization. So, and then while you could argue that these arrangements incentivize cost-effective care, which I think they can do, they're incentivizing the healthcare providers to provide high quality, really cost-effective care so that there is, in theory, some profit at the end. You can easily see how they might start to incentivize simply providing less care, right? So if I'm paid only if there's profit on my subset of patients, maybe I don't want my patients to spend any money, so I stop making referrals and stop sending them for the workups that they need and such. I've never seen it happen quite that extreme, but we talked about how every contract sets up incentives, and sometimes those incentives can be distorted. So again, this whole notion of risk shifting from insurance companies to healthcare providers is just a fascinating sort of trend over the last decade or two in healthcare. So let's switch gears and talk a little bit about VBC or value-based care. It's been a very commonly talked about thing over the last decade, maybe even 15 years. But let's start by how we define value-based care. So I just went to CMS's website, CMS's Center for Medicare and Medicaid Services, cms.gov is their website. And this is how they define value-based care. Designing care so that it focuses on quality, provider performance, and the patient experience. Sounds simple, but you will actually get many, many different definitions and terms that people use basically to explain a similar concept of value-based care. So associated terms that you'll sometimes hear: accountable care, person-centered care, integrated care, coordinated care, patient-centered care, again, a whole variety of terms that are essentially all trying to get at the same thing. And it's important to understand that value-based care is often juxtaposed with volume-based care, right? So a fee-for-service model incentivizes volume, more patients, more RVUs. You could even say a capitated model just incentivizes taking care of more and more patients, so similar kind of volume-based. This model is really saying it's not just about more care, it's about providing the right care. So care that's tailored to the individual, care that acknowledges that we want to provide high quality and cost effectiveness, care where providers are held accountable for the work that they do. And I would call out that value-based care implicitly acknowledges that much of healthcare has historically and maybe is still currently low value. That is to say, costs way too much for the outcomes that we are getting. And it's not news to any of you that in the United States as a whole, healthcare is many times more expensive than other developed countries, and yet overall measurable quality is often lower. So care as a whole in the United States is pretty low value care as it stands currently. Value-based care is an attempt to shift that. So And then I would make the important statement that family medicine is value-based care. I mean, this is what we do, right? We provide care that's individualized. We provide care that it acknowledges the individual patient's goals and history and background, often acknowledges multiple generations of the family and what they prioritize. It's really focused on providing high quality care. Family docs often focus on cost-effective care, not just for saving money for the system, but because they want to save money for their patients. And they know that many patients have high deductible health plans these days. Most family physicians that I know are totally willing and comfortable being held accountable for the things that they can control and the care that they provide. So, when you talk about value-based care in my ears, that's just, yeah, family medicine. That's what we do. That's how we work. Let's talk a little bit about making care primary, and this is a nice way to kind of pull together all that we've talked about around payer-provider contracts and how these contracts are often layered in different ways. So first, what is making care primary? I'm sure many of you have heard of this. It is a new innovative payment model from CMS and CMMI. CMMI is Center for Medicare and Medicaid Innovation. And so it's a sub-organization within CMS that is trying to figure out how to make healthcare work in a sustainable way. I think we all know that traditional Medicare and healthcare more broadly in the United States is not on a sustainable trajectory currently. You'll hear different estimates, but sometime over the next few decades, in theory, it might bankrupt the entire US economy, which is a huge problem. And so I think there's recognition at CMS's level that the traditional fee-for-service payment model is not the solution and is not working, and we need to start innovate and trying different models to improve the quality while reducing or managing the overall cost growth of healthcare. So over the years, they've been trying a bunch of different models, Medicare Shared Savings Program, ACOs, CPC, CPC Plus, again, a whole long list, direct contracting entities now renamed ACO REACH program. All these are innovations from CMS and CMMI. Making Care Primary is the latest one. Making Care Primary is a 10.5-year, 3-track pilot program that will run in 8 states. Washington is one of those states, and this program actually launches in July. So some of your organizations may be joining this program. Family Care Network is launching into this program. The 3 tracks, you basically move your way through the 3 tracks as you progress through those 10.5 years, but all participants eventually end up in track 3. And I've participated in a bunch of the information sessions and webinars around Making Care Primary. What is abundantly clear is that if this model works, CMS will expand it. And their goal has for years been to get every single CMS patient, Medicare patient, into some type of advanced payment model in the not too distant future is what they would say. Years ago, the not too distant future was 2024. We're not there yet. And then for a while, they were saying 2027, and the latest I've heard is 2030. Who knows what the actual timeline is, but clearly something needs to change to make healthcare more sustainable in the US. And then the overall model structure, and this is why we're going to walk through it, reveals how CMS is thinking about what value-based care should look like. And a really interesting call out with this model is it's called Making Care Primary. Obviously a little bit of a play on words, but it's really a primary care focused model. That's really what it is we're saying we want to build up and support primary care, and this is how we're envisioning doing it. So let's talk about what payment looks like in track 3 of this model. So track 1 and track 2 are kind of interim steps, but as I said, every participant in the pilot ends up in track 3. So there's a base payment, which is called the prospective primary care payment. It is a simple capitated payment amount. So at the start of each month, paid prospectively, every attributed member to that primary care provider, there's a monetary payment to that primary care provider, to that organization, fixed. It's essentially a per member per month rate. So this is a capitated model. It's a huge shift for CMS because, again, traditional Medicare has always been fee for service, but this is moving to a capitated model for primary care. The second tier is there are some carve-outs in addition to the cap. So services provided outside of sort of traditional primary care. So OB work is not relevant to Medicare age population, but procedural work is a good example. So a bunch of different procedures are not included in that cap. And so that's really saying, you know what, if you really provide broad spectrum of care as a primary care provider, we will pay you the cap, but we'll also acknowledge that we really like the fact that you're doing all this other work, and we'll compensate you for that above and beyond. And why do they want to do that? Because it's almost always cheaper to have primary care providers provide care than specialists. And so they're incentivizing that through these carve-outs. What's the next layer? They have what's called an ESP, or enhanced service payment. And this is a payment, I believe it's paid on a quarterly basis based on the HCC risk scores of the population of patients attributed to any primary care organization. And so that's a really fascinating thing. The way that CMS has explained that is sicker patients require more care and more resources to effectively support them. We want to pay you, primary care providers, more money so that you can commit to providing that more comprehensive care. And whether that's care management or a whole variety of other services to really meet the needs of sicker patients. It's interesting that CMS is willing to spend more money on sicker patients. I think they're acknowledging the fact that if we can keep those sicker patients more closely connected to their primary care providers, in the long run, the system will save money because these patients won't bounce in and out of the hospital and in and out of the specialist office quite as frequently as they otherwise would. And then the final piece is a performance incentive payment. And I didn't want to write out there's, I think, somewhere between 11 and 14 different incentive measures, but they are preventive care measures, chronic disease measures, and utilization measures. And that is it. That is essentially what they have included. And so that performance incentive payment in track 3 is up to 60% of the prospective primary care payment cap. And so again, really significant upside with that performance incentive payment. So this is a really good example of what those layered contracts look like, right? So it's a cap model with additional carve-outs, with some payment for sicker patients, the enhanced services payment, and then we want to add some performance incentives on top of that as well. So again, this is what these contracts often look like these days, this sort of layered approach. So since family docs provide primary management of patients, do most of the HCC coding and almost all of the quality and utilization work, they should be financially rewarded in this model. As a whole, this model looks very promising in that it looks like it's shifting more money clearly towards primary care. In large healthcare organizations, will the family docs really experience all the benefit of that? I'm not 100% sure how they'll manage this additional influx of funds, but ideally it would, because again, this reflects the work that family docs do. So again, making care primary, pretty exciting development. So and then this is, I think, the final slide before we do the summary. So just want to call out that value-based care is shifting more dollars towards primary care. So CMS has fully embraced value-based care and the idea that investing more in primary care will improve quality while reducing costs. And again, that shouldn't be news to anybody on this call. We all know that the more money you spend in primary care, you save everywhere else across the healthcare spectrum. I saw a recent study that said for every additional dollar spent in primary care, $13 is saved elsewhere in the sort of global healthcare spend. And so CMS has realized that and has said, you know what, a solution to managing cost is shift more money into primary care, and then let's watch the savings everywhere else across the healthcare spectrum. Some other things CMS, or some specific things CMS has done to do this. In 2021, some of you may recall they reweighted, so they changed the RVU values associated with E&M codes. E&M codes are what we family docs use most frequently. Many specialist surgeons, they use the procedure codes, and there's a long, interesting history as to why procedure codes were so heavily weighted with RVUs. CMS has said, nope, we're going to switch that around. So we're going to significantly increase the RVU weighting of E&M codes, and that has a very explicit effect of shifting funds back to primary care, or really any provider who uses those E&M codes extensively. Again, primary care being the prime beneficiary of that. So that was in 2021. In 2024, January 2024, this G code, I think some of you are familiar with this, G2211, went live. It had actually been agreed to several years before, and then there had been delay in starting payment. But essentially what that code is it acknowledges that the relationship between a primary care provider and a patient requires extra work. The fact that there is that relationship, it means that the job of the primary care provider is more complicated than, say, an urgent care provider or an ER provider, or what have you. And we want to provide some additional funding, acknowledging the importance of that relationship, but also the added work that comes with that long-term continuity relationship. And so G codes typically reimburse about $16 or so from CMS per visit. And really, it should be added with the vast majority of primary care visits. If you are seeing your own patient that you have assumed primary care responsibility for, that G code should be billed on top of anything else you bill during the visit. Again, shifting more money back to primary care. And then launching a new pilot program like Making Care Primary. Again, just another example of let's get more money directed towards primary care and trust that that will help resolve much of what ails healthcare in the United States. So I would also call it that HCA, which is the Healthcare Authority, they administer Medicaid in Washington State, is fully embracing the Making Care Primary payment methodology and really wants to align around that model. In fact, they want the entire state to align around the Making Care Primary model. They even want private insurance companies to align around that model as well. And so there are efforts being taken to say, we should all dive into this Making Care Primary approach. We should all prioritize primary care. We should have contracts that mirror that making care primary sort of layered contract approach. And we should all be in agreement that this is the direction we're heading. So pretty easy to envision that it's not just traditional Medicare, but Medicaid in the near future. And then, if they can do it, HCA would like to motivate private insurance companies to align around a very similar model as well. So all focused on shifting resources back to primary care. And then again, private insurance companies are motivated to improve quality while reducing costs. Improving quality is something that they can market, and in some instances directly beneficial to them financially, like through Medicare Advantage programs and such. I'll spare you the details. And then cost-effective care benefits the insurance companies as well. And so they are increasingly interested in supporting and diverting money to primary care. So while I'm not confident that many employed family physician contracts acknowledge these changes, they should. Again, I'm not an employed family physician, so I don't see those contracts, but really recognizing more money is coming into healthcare organizations through primary care than it ever probably has in the past. So, all right, this takes us to the end and the summary. Thank you for bearing with me through this. So summarizing the key points of the third module that we just went through. Payer-provider contracts create incentives, which can be great, but can also be manipulated in ways that sometimes work against a patient's best interests. As you read these contracts, it's always valuable to think through what incentives are we creating, explicitly or implicitly, in how these contracts are written. Fee-for-service and capitation are basic payment approaches, often with added incentives and profit or loss sharing agreement as well. Value-based care is the future of healthcare in the United States, and success in any value-based care agreement requires effective family physicians, or at least effective primary care providers. Family medicine is value-based care. So I think that's an important statement that I would tuck in your brain. And anytime you hear your administrators talking about value-based care, raise your hand and say, hey, you know what? That's what we do. I'm a family doc. That's exactly what I do day in and day out. That's the type of care that I provide. Those are the values that I have. Again, family physicians should be elevated as value-based care becomes more and more the norm. And whether through reweighting RVUs towards primary care services, through E&M codes, adding the G code G2211, or making care primary, it is clear that CMS is working to shift to more money towards primary care. So I've said this with the previous two models, but I'll repeat again. Now is a really great time to be a family physician. And if anybody is on this call as an early career family physician, you picked a wonderful time to come into this specialty, because I think over the next 5, 10, 15, 20 years, the future is enormously bright. I've been in medicine, started medical school 22 years ago. I think now is a better time to be in family medicine than it ever has at any point, at least in my career. So again, the future is exciting and bright for all of us. So before we get into the Q&A, just a reminder, our fourth module, which is Tuesday, June 11th, 6:30 p.m. is the outline is understanding how healthcare executives see the world and what that means for you. So hard to make time on what I'm sure will be a sunny night Tuesday in June, but if you are able to join us, we would certainly welcome your participation. All right, that takes me to the end of my comments. Thank you for bearing with me.